Okay, so good evening everyone and welcome to the 19th session of the online Optom learning series. And we are glad to have Professor Bruce back with us. And as the discussion goes on, I think some of you are concerned about how is he and how's everything at his place. He's doing well, and he has taken up this time again to brief us about the cases of pediatric refractive error management. And I don't think I need to introduce Professor Bruce to you. He has a vast experience in pediatric optometry, and we all are eagerly waiting for his talk 2, where he is going to discuss more of a case and clinical scenarios. So, Prof, you can start now. Thank you.
Okay, well, thank you very much. We're doing fine here in the U.S. We had a power outage in my part of the country. It's related to a big snowstorm we had a week and a half ago. And at my home here outside of Boston in the state of Maine, about 250 miles north of Boston, we lost power for almost a week. So that's why I couldn't do the talk last week, because we had no electricity and no phone service. So anyhow, I'm back, and I want to try something a little bit different than the usual lecture format. I'm going to first go over a couple of points that I made last time. I want to just emphasize those things. And then we're immediately going to go into some cases, some general cases. And I want to try to see if we can get feedback from all of you. So as I'm asking some questions, if you can respond, and our moderator will then feed me some questions verbally, and we'll try to answer it and go back and forth. And I want to try to make this as interactive as possible. I don't want to just sit here and run my mouth for an hour. I want to get your input. Okay, so first slide. I think this is important. I just wanted to give what we in the US call a financial disclosure slide. And what that means is that in the US and in Europe, we are very much required every time we speak or any paper we submit for publication to really be very clear about what kind of financial support we may be getting from a company, a manufacturer, or grants that we may have gotten from some source. We do that so people have a really good understanding of where our talk is coming from. So a lot of what I've presented last time and this time is based on work that I've been doing for 25 years now as part of a very large funded research study from the United States Department of Health and Human Services, the National Eye Institute, National Institutes of Health. The study is called the Vision of Preschoolers Study. The most recent phase of it specifically concerned hyperopia in preschool children. So I've been particularly interested in the question of the effect of hyperopia on children beyond just the vision part of it, the learning part as well. I also want to say that in the recent past, I've gotten some financial support from Welsh Allen, now part of a company called Hill-Rom. You're probably all familiar with Welsh Allen. Their ophthalmoscopes and retinoscopes are more likely than not from Welsh Allen. They also make other equipment, and I've been doing work with them on the Spot Vision Screener, which is a photo screener. So I wanted to make sure that you understood that I do get some financial support from them in the past. I mentioned that in children, and of course my talk is really about children and more about young children, the critical aspect that is different from the general practice of refraction is that your refraction technique has got to really be objective in nature. You are relatively unable to get typical responses from children. Young child is not going to be able to name letters and do other kinds of subjective responses. So you've got to get the information any way you can by observing the child's behavior, by observing certain test findings, and then integrating all of that. I also mentioned last time the critical nature of being able to do cycloplegic refractions. I totally understand that in many of your situations, you are not in a position to be able to use cycloplegia. I understand that. I understand also that it provides complication to your approach. It makes it more difficult to fully understand what's going on with a child's refractive state, in particular, kids with moderate to high degrees of hyperopia. I mentioned last time that in the research study, the VIP study, we found that even the most highly experienced pediatric ophthalmologist and optometrist will only be relatively accurate, even moderately accurate, in their refraction in detecting moderate to high degrees of hyperopia only 90% of the time. That's a nice way of saying with a dry refraction, even experts are going to miss at least 10% of kids with really important refractive errors that we want to know about. Those kids are going to be missed. That is a problem. You're not going to find that out unless you do cycloplegic refractions. In my own experience, I have been, I can't say surprised because I expected. I have found that kids that I refracted dry that looked like they were moderate, low refractive errors turn out on cycloplegia to have high hyperopia. So that happens to everyone. We talked a little bit about managing refractive error, and I said that there are 3 principles that I feel are really important. I will not provide refractive correction unless I believe it's going to improve vision or improve binocularity or improve visual functioning. And I really strongly believe that. Now, I also said, and I think this was probably the single most important thing I said last time, probably the most important thing I'll say today. The principle of correcting refractive error, as far as I'm concerned, is to put a focused image 360 degrees on both eyes simultaneously. I want to make sure that both eyes are corrected refractively and are in focus, that focused images are projected onto the retinas of both eyes simultaneously. A lot of what I'm going to talk about today in terms of cases is really going to be directly related to that. Now I'm going to skip through some stuff and get to the topic today. Okay, so here's a case. This is a very typical situation in my experience. 3-year-old child comes into your office. The history in this case, and it's just hypothetical, is that the child appeared to have perfectly normal, healthy eyes. The parents noted no issues of any kind whatsoever. But last week, the child developed a fever and a cold and a cough, hopefully not COVID-19. Child probably developed a viral infection, typical in kids. For any of you that have had a young child, you know this happens all the time. For all of you, I expect you all had the experience yourselves when you were young, getting viral illnesses all the time. You were healthy one day, you were really pretty sick. So this child woke up the next morning, all right, up sick. This child had a fever. This child was throwing up. This child suddenly had crossed eyes. That was the thing that made the mother nervous. She looked at the child had a right eye that was crossed. Okay. Child was sick for a couple of days. The crossing went away when the child got better after 2 or 3 days. But then over the next couple of weeks, the mother would see when the child was really tired or crying or something along those lines, not at 100%. That right eye started turning in a little bit, sometimes just a tiny bit. The mother wasn't sure if it was happening or not. At other times, just before the child was ready to fall asleep, and that child was getting to doze off, that right eye turned, and it turned a lot. That brought the mother in for a visit with the child. And on my examination, visual acuity by Leah symbols or whatever other technique you would use appeared to be good in both eyes, equal. Refraction, dry refraction indicated some moderate plus. My cycloplegic refraction indicated what you see on the screen here. So moderate degree of hyperopia, more hyperopia, and somewhat more astigmatism in the right eye than the left eye. Binocular status was fairly normal most of the time, but in doing some of the more dissociative stereo testing, binocular testing, binocularity apparently went to 0. So depending upon the stimulus of the test, the binocularity might have been normal or might have been abnormal. Okay, so what are we going to do? What are we thinking about? What's going on with this child? Well, this is, I think, a very common problem affecting maybe 3 or 4% of young children. This is accommodative esotropia with slightly unequal, moderate hyperopic astigmatic refractive error. So the eye with a higher refractive error, even though the spherical equivalent was not too different. Let me just flash back to that. So you look at the spherical equivalent, yeah, a little bit different, but not all that much. But the reason the right eye was crossing, because that's the eye that is typically more out of focus. Now remember what's going on. The left eye is accommodating under normal circumstances to eliminate most of that hyperopic refractive error. So it gets down to something approaching emmetropia with a little bit of SIL. The right eye, however, still is exhibiting a little bit of hyperopia. Nice way of saying that right eye is blurred a little bit. And if an eye is going to start turning or crossing, that's the one that's going to happen. So what do we do? Now, let me give you a second possibility. Let's say in the second possibility, instead of the visual acuity being equal, and the reason that it was equal in the first case is because the crossing, the strabismus, the accommodative esotropia, was just beginning now. It had not had time to set. So the visual acuity on the right eye had not really had an opportunity to decrease dramatically. Let's give the example of now that eye has been crossing for a longer period of time, maybe weeks or a month. The visual acuity that we measure on that first initial visit is now asymmetric. It's reduced on the right eye. It's relatively normal on the left eye. Let's say that there is a 2-line difference in visual acuity. Well, that meets most people's definition of amblyopia. But let's say there's only a 1-line difference in visual acuity between the two eyes. Is that amblyopia? Well, from a formal definition, maybe it's not. From a clinical definition, it absolutely is. So in my view, any difference in visual acuity that has amblyogenic risk factors attached to it, in this case, unequal refractive error and isometropia, meets the criteria of amblyopia. Now, if we were to do a complete ocular health examination, we would find no other ocular health issues going on, no retinal problems, no brain tumors, no other stuff. So it also meets diagnosis of exclusion. There is no other disease entity going on. But there is inclusion because there is a difference in one of the amblyogenic risk factors, in this case, an isometropia. So let's go back. Let's say visual acuity was equal. What are we going to do? Visual acuity is equal. What we would do would be to go ahead and prescribe glasses. What glasses would we prescribe? Would I give full plus, my cycloplegic, or reduce plus? I would typically reduce the plus because the eyes are straight at least some of the time, and probably giving most of the hyperopia, but not all of it, would suffice. So I probably would cut the plus by 3/4 of diopter on each eye. So I'd give a +4 on the right, I'd give a +3 on the left, and I would give the full SIL. Remember what I said the last time. Focused image 360, both eyes simultaneously. I do not want to change the difference in hyperopia between the two eyes. I want to maintain a 1 diopter difference to put that focused image on both retinas. I also want to fully correct the astigmatism because I want that focused image 360 on both eyes simultaneously. So prescription I would give in the case of equal acuity would be +4 minus 175 axis 180. The left eye +3 minus 1 axis 180. All right, what would I do if there was some difference in visual acuity? Would I do anything differently? Answer, no. I wouldn't do anything differently. The ATS studies, the amblyopia treatment studies carried out by the Pediatric Eye Disease Investigators Group, as I mentioned last time, a series of about 25 incredibly detailed research studies done in the US and Europe and Canada, looking at various aspects of the treatment of amblyopia, has determined unequivocally, without any question whatsoever, the first step in treatment of amblyopia is provide appropriate refractive correction, and that appropriate refractive correction is focused image 360, both eyes simultaneously. So it's okay to cut the plus, it's not okay to cut the CIL, maintain the difference between the two eyes if there's an isometropia, put that on the child, leave it on the child, monitor the visual acuity changes over a period of time. How often? I would see the child back either in the example of the eyes, of the acuity being equal or unequal. I'd see the child back in about 2 to 4 weeks, something like that. I want to see if, number one, the kid's wearing the glasses without too much difficulty, and number two, I want to see what effect the visual acuity or the proper correction of the refractive error is having on visual acuity. I would continue doing that until there is no further improvement in visual acuity. If visual acuity improves to normal on the right eye with glasses alone, then I would probably need to do nothing else other than eventually pick up vision therapy to do full binocular workup, determine if there are any deficits in binocularity, and if there are, then I would absolutely go ahead and think about the appropriate stages of vision therapy to do on the child. If the acuity normalizes, if the binocularity is normal, then the optical correction alone solved the problem. Now, let me say this very clearly. The ATS studies have shown that in the case of refractive amblyopia, which accounts for the majority of cases of amblyopia, either as a pure form of refractive amblyopia or as a mixed form of refractive and strabismic amblyopia. And in this case, you could easily argue that this is a mixed form of both strabismic and refractive because there was an accommodative esotropia. 50% of the time in these situations, providing appropriate refractive correction alone solves the problem. You do this step first, and then only after this step, the correction of refractive error has gone on long enough, only then, if there still is a visual acuity deficit, do you then begin doing other active forms of treatment in the form of either patching or atropine or the binocular techniques that were mentioned in the talk the other day, which are perfectly appropriate. And as I also said on my last talk, ultimately over the next 10 years, that's going to become a dominant methodology of treating amblyopia in an active way, is using binocular techniques and not penalization of either putting a patch on an eye or atropinizing the good eye. So ultimately, binocular forms of treatment are going to be what we're going to do. So let me just reiterate what I've said. Either in the case of acuity being equal or acuity not being equal in this situation, step one, glasses, monitor, find out what the visual acuity is doing. If the visual acuity equalizes and binocularity gets to normal levels, then you're done. Although again, you may consider doing vision therapy to enhance binocularity. And if the visual acuity does not completely return to normal, if there's still some deficit, only then would you initiate additional treatments. So I'm going to stop there, and now I'd like to entertain some questions and some comments from you. So please submit those to our moderator, and he'll mention those to me.
Okay, Prof, I'll just wait for the answers to come in. There is a request, Prof. Is it possible for you to display the slides full screen?
To display which slides?
Your slides, can we do it like a slideshow if that's possible? Because some of them I think cannot see your slides because it's half screen.
Can't see the slides. Oh, let me see if I can.
Yeah, at the bottom there at the
let's see.
slide. The window is too small.
Try to figure out how to do that.
Okay.
I don't know how to make it full screen.
Bottom right of the PowerPoint. There's some
PowerPoint. All right, let me go to that. Yeah, yeah.
Not that one. That one is slideshow.
Yeah, I think that's also okay if Prof's fine with it.
Okay.
Yeah.
Okay, I can't get rid of the other stuff.
Oh, that's the software
Is that
thing.
better?
Oh, okay.
Is that okay now?
Yeah, it's okay from our side, but does it bother you, Prof? I mean, is it okay?
No, that's fine. That's fine.
Yeah. Okay, so we have got a couple of comments here. One person says that, yeah, they follow the same strategy. They are from Nepal. So I think Nepal is following the same strategy. That's what one of the comments says. The patient you discuss.
Actually, let me just point one thing out. I also spent some effort on the last talk talking about the critical nature of evidence-based optometric practice. This is now the evidence basis. The amblyopia treatment studies and now a whole range of additional studies that have been done in addition to the ATS studies. They've really shown that step one, without any question at all, is provide a refractive correction before you do anything else. Okay.
Okay, and then the patient you discuss who is having esotropia or esotrope. So what are the insights on options of fully correcting the patient?
Okay, good question. So one of the downsides of giving that full cycloplegia correction that's on the screen now is the possibility that child may not accept wearing the glasses at all. So as we all know, giving full cycloplegia correction requires a child to release all that latent hyperopia that's there, all the facultative hyperopia. In other words, you got to really reduce the accommodative demand completely. Is a child who has been using accommodation in an abnormal manner, which is, of course, the reason for the accommodative esotropia, are they going to be able to reduce all of that? The answer is maybe, maybe not. But I would start out at least with the partial correction. If I found that it improved visual acuity, but did not completely deal with the esotropia, particularly the esotropia near, at that point, I might increase the amount of distance correction to something approximating what's on the screen now, or alternatively, provide bifocal correction. I might do that. Now, let me give another example. What if I put the reduced correction on the child and the child would simply not tolerate wearing the glasses, would just scream and complain, everything is blurred, I can't see, I take the glasses off, I see better, Mom, throw these away, I can't stand it. What I would do under those circumstances is something that you may not be in the position to do. But what I have done for my whole career is then gone ahead and done something maybe a little clever, maybe a little mean. I go ahead and I put atropine in both eyes of the child, and I keep that up for weeks at a time. So I will atropinize both eyes of the child, and in a sense, force the child to accept wearing the full correction or even a partial correction. In other words, I'll make it so that the kid can't see without putting glasses on. And I've done that for years, and some people think that's mean or crazy, but I've actually found that it works most of the time. Sometimes the difficulty is convincing parents, but I frankly have not had a lot of difficulty convincing parents to do what I ask them to do. I take the approach that I'm the doctor, I know what's best. If you went to your doctor, mom, with some complaint, some medical problem, you would probably listen to what your doctor said, whether or not you liked it or not. And I find that I could do the same thing. If I act like a doctor, people treat me like one and they respect what I recommend. So that's how I approach it. I will sometimes be pretty tough. Now, if the initial partial correction improves vision but does not improve completely the strabismus, then I'll push more plus and or provide a bifocal correction in addition. Hope that answers the question.
Yeah, and I think some of them also asked that can we prescribe bifocal spectacles in this case? So I think it was well covered in your explanation here.
Yeah, I won't do it as a first treatment usually. I'll usually do distance correction first. Part of the reason for that is the cost of the glasses and just the acceptance by the child. So it's just been my experience that trying bifocals first is sometimes less successful in terms of management than going with single vision first and then adding bifocals later if needed.
Okay. And yeah, and somebody says that if it's an accommodative esotropia, normally we don't subtract the 0.75 and would rather prescribe the full cyclocorrection.
That certainly is an argument. What I could say is that my experience has been that usually reducing by only a small amount still gives me the benefit that I'm looking for and increases the level of compliance of accepting the glasses. So I certainly, under some conditions, might decide to give full correction, but in general, my experience has been reduce it a little bit. But I think if you have been using full correction and it works for you, I'd say that's fine. Again, what I'm saying is not the law. It's not gospel. It's my experience superimposed over the evidence basis that exists today. But certainly evidence basis can be modified a little bit by clinical experience and in particular by the particular patient sitting in the chair in front of you. Okay?
Okay, and somebody is asking that do you prefer to use myotics in the treatment of accommodative esotropia in this case? So would you do myotics?
In the myotic eye drops?
Yeah.
Yeah, actually, you're talking about something like phospholine iodide. To be honest, I don't think anybody in the U.S. uses those drugs anymore. I think there's been a decreased reliance on them. I think a decreased belief of their usefulness. So I think using this approach that I've talked about is the one that most people use. To be honest, I haven't even thought about myotics in probably 20 years. And I haven't even heard of anybody in the US ever using them anymore. I don't even know if they're even available anymore. They might be, probably are, but I haven't even thought about it in 20 years.
Okay, so it's not that famous there, so probably, yeah. Okay, and there's one more comment on that. Can we go for a full correction and a nasal block in the right eye so that the below correction may cause the ESO increase? I'm not sure what nasal block means, but
yeah, well, I think you're referring to putting sort of an occluder nasally on that eye to try to get that eye looking straight. I think some people might think about using something like that later on. Certainly ophthalmologists wouldn't. Probably some behavioral optometrists might consider that. It's not something that I've ever done. And in my experience, I haven't really needed to resort to something like that. But I recognize that there are some behavioral optometrists in the US that would think about something like that at an early stage. But again, it's not something that I've ever used.
okay. And there's one query on balancing. So the question goes that after finishing the binocular balancing test, some of the patients might have reduction in the vision monocularly. So what should we do normally in those cases?
Okay,
Should we
that's a
give the
wonderful
correction or
question.
balance?
It's a wonderful question because it gets at how do you do a binocular balance test on a 3-year-old child, which is really the essence of the question. Can you do a binocular balance test by trying to equalize visual acuity in a child with amblyopia? And the answer obviously is you can't, because the amblyopic eye is never going to give you the type of responses that are going to allow you to proceed in that manner. So how do you go about doing a binocular balance test? Well, it's something I've thought a whole lot about over the years because a lot of my experience has been with very young children under the age of 5. I'd say 2/3 of my experience in 45 years on probably hundreds of thousands of kids has been on young kids, which is a nice way of saying you can't really depend upon visual acuity responses of young kids, particularly in a child with amblyopia. The visual acuity response is only an approximation at best. So the way that we do a subjective binocular balance test, there's a couple of different ways. One way is to use the duochrome test on the right eye and then use a duochrome test on the left eye. But I don't like the duochrome test anyhow. I don't like the red-green test. I'm color defective. I have a moderate deutan anomaly. And whenever I tried, when I was in optometry school long ago, had people do the duochrome test on me, I would always say red, 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 no matter what. I always favored red. And I've learned that actually through my experience with others, with color vision defects, males obviously, that you don't get reliable duochrome testing on individuals with color vision defects. So for me, I never really depended on duochrome. I've never really liked the test much. The test that we teach at NECO, and is I think probably more widely used in the US, is the binocular balance test using prisms, base up and base down. So you come up with your approximate RX on the right eye and the left eye. You then put dissociating prisms in front, you blur, and then you reduce the blur until they're equal, and you proceed. Can that work with somebody with amblyopia? No. So binocular balance test in that way isn't going to work either. So doing a subjective binocular balance test, in my view, with an individual with amblyopia or compromised vision in any other way is simply not possible. So how then do I determine binocular balance? In my view, there is only one way to do it, and that is going back to what I said before, depending on objective testing. What objective test do you have that gives you refraction information? Called retinoscopy. As optometrists, we all know how to do retinoscopy. We're all pretty good at doing retinoscopy. Ophthalmologists often less so, and in some cases not at all. My experience, pediatric ophthalmologists are very good at retinoscopy. Pediatric optometrists are very good at retinoscopy. Other ophthalmologists who don't use retinoscopy a lot in clinical practice, not so good. But if we're pediatrics people and we work with kids a lot, you're pretty good doing retinoscopy. How do I do retinoscopy in a binocular balance way? Instead of me sweeping only the right eye and then a moment later sweeping the left eye as a final step, after I've come up with a determination of the right eye and the left eye by retinoscopy, I then do what I call a binocular retinoscopy technique. I very rapidly sweep across both eyes really fast, kind of like that. And I'm balancing based upon the reflex. So I also move closer and further away. I do that along with changing lenses. So I have lenses in front of both eyes. I'm sweeping both eyes, and I'm making very slight adjustments as I'm going along until I get binocular balance. And I'll hold 4 lenses. I don't use a trial frame typically. I will hold 4 trial lenses, sphere and sill, in front of each eye, rapidly sweeping both eyes, until I get what I believe is equality. I don't know of any other way of doing that. I don't think there is any other technique of being able in an objective way to do that. I'll stop there and let me open it up for some questions about that. I think that's important.
Yeah. Do you want to take one more question, Prof, regarding the case? I think.
Yeah, sure. Yeah.
Yeah. Okay. So there's. I think you have answered this. That some people are asking what your insights are about the full cylindrical correction. I think you mentioned you would probably give the full correction all the time in terms of cylinder.
Actually, I would not probably give it. I would absolutely give full correction of the sill. And I would do it both with the sill and with the axis. I depend upon my retinoscopy. I do not depend upon a subjective, particularly on an amblyopic eye.
Okay. And yeah.
I'll go on then.
Yeah.
So the next case is an Anisometropia. Classic. 5-year-old child failed the vision screening at school. Parents never noticed the problem. Did the screening. Visual acuity on the right eye was terrible. Visual acuity on the left eye was normal. Parents never noticed a thing. This was a complete surprise to them. They thought the vision screening was wrong. On my examination, this is what I found. I found high myopia on the right eye. I found essentially emmetropia on the left eye. What do we do? So first of all, let's talk about what is the potential cause of unilateral high myopia. And when we think about myopia in general, I think we all acknowledge nowadays that myopia is determined by a combination of genetic and environmental factors. We recognize that in kids who do tons of reading in darkness and never go outside, they're far more likely to become myopic. We know that kids who don't do a whole lot of reading are less likely. We know that if a child has 2 parents that are moderately to highly myopic, the odds of that child ultimately becoming myopic are very great. So again, genetic factors determine quite a bit. Environmental factors also determine quite a bit. So how do you get a kid with high myopia in one eye and nothing in the other eye? Is there a gene for the right eye for high myopia and no gene for the left eye for myopia? Well, I think we recognize that that's not possible. So something must have gone wrong. And I think it's interesting to me that there has been relatively little research done on the etiology of unilateral high myopia, but there's been a little bit. People don't talk a whole lot about this situation. They don't talk a whole lot about why this situation occurs. They talk endlessly about the myopia epidemic occurring around the world today, but they don't talk about the etiology of unilateral high myopia. So let's go back a little bit to some basic science I learned early in optometry school. You may remember some of the studies done on the development of myopia in animal models. You may remember that if you occlude one eye of a monkey or some other mammal, or a chicken for that matter, from birth on, then you can induce high myopia in that eye. So it induces a mechanism of axial elongation. Light deprivation can do that. So can we think about how that might pose a scenario that might account for what we see on the screen right now? And I think we can. And I had a little bit of experience with this when I was doing a study long ago, looking at the longitudinal changes in refractive error from birth out to 4 years of age. When I was at Children's Hospital at Harvard, we published a seminal study, probably 35 years ago, looking at the natural history of refractive error from birth out to 3 or 4 years of age. And there are others doing the same work. What we found is that there's a moderate degree of hyperopia on average present at birth. That tends to decrease through the process of emmetropization by 3 years or so of age. So you get a fair amount of hyperopia early on. There's a whole lot of variability. Some kids are high hyperop, some kids are low. There's some myopia thrown in. There's a whole lot of scatter on a scattergram. It's a nice way of thinking about it. And then pretty rapidly in the first year, that scatter decreases, emmetropization takes over, things get less. But we did find some kids that had unilateral and bilateral high myopia right from birth. What did we notice on some of those kids? They had cloudy corneas, or they had evidence of having had corneal trauma either during the birth process or maybe through some fetal event. And what you can see are vertical striae in the retina. I'm sorry, in the corneal stroma. You see vertical striae in the corneal stroma of some of these kids that tends to fade somewhat over time, but does not always go away. It's an indication that there was corneal edema that may have been caused by some form of birth trauma, maybe forceps delivery, maybe some other insult to the fetus or to the baby being delivered. Most of the time, that corneal clouding goes away and leaves virtually nothing behind. There may still be some striae in the corneal stroma, but there may not be. So one of the possibilities is that insult to the cornea at birth may cause these unilateral high myopes. Can't be genetics, and it's hard to imagine environmental influences happening later on. Now, we followed a bunch of these kids over time, and it turned out that the level of myopia really does not change very much in most of them. And I suspect that in your own experiences of your patients, where you've seen at a younger age something like this, you follow them for a period of years and you don't see much change. That's different than the typical myopia that you see that obviously has a strong tendency to progress. These kids don't progress. Okay, so what do? This kid shows up at 5 years of age. You do anything about it? Well, to me, one really important thing to do is to ascertain if the retina is okay. So you'll recognize that with really strong axial elongation, you've got a stretched out eyeball. And in stretching out the eyeball, you're obviously causing retinal events to occur. You're stretching the retina. You get thinning of the retina, you have a propensity for retinal detachments, but you also get adverse events happening in the macular area. You may be getting breaks in Bruch's membrane in the retina. You remember that? So if you get breaks in Bruch's membrane, you got a bad macula. You have a bad macula and a bad fovea, you're not going to improve visual acuity. So if you have a broken retina, the likelihood of regaining vision is poor. Now, in the old days, we really had to look with an ophthalmoscope, either a direct or a binocular indirect, and try to ascertain the status of the retina, the macular area of these kids. Hard to do, particularly at a young age. Now we have a tool, OCT, that allows us to get exquisite topography of the retina in the area of the macula. So we can use OCT to evaluate the integrity of the macula. And if we find that it's a healthy looking macula, then absolutely positively go ahead and try to improve things. Now, one question that comes up is the visual acuity in this case, is it reduced because of a high myopia alone, or is there in addition an amblyopia component? Now, we don't know at the beginning whether that's the case or not. There's no way to really know. There may be some amblyopia. I mean, typically it is said that myopia does not cause amblyopia because there is a finite point in space where there is a focused image. In other words, if a kid holds their hand really up right in front of their eye, there is some position a few millimeters, centimeters away from the eye that is actually in focus. So can that cause amblyopia? Who knows? Maybe, maybe not. That's probably the best we can say. So what's the best approach? I'll go back to what I said earlier. Focused image 360, both eyes simultaneously. That means you got to provide correction. What correction do you provide? Well, I'm going to guess that many of you will think about magnification and minification and Knapp's law and think about, well, I can't give 8.5 diopters of correction because it's going to cause all kinds of anisometropia, all kinds of anisoconia. It's going to cause anisoconia. My argument is, you don't put a focused image, you got no hope anyhow. Obviously, the right eye is never going to be a dominant eye. It's never going to be a normal eye. That eye is never going to see 20/20. The other eye is. So what do? I would go ahead and I would provide the full correction. Now, I probably would give plano on the left eye. I'd probably modify the other eye to, say, an 8 with sill. I probably would give no sill on the left eye, just plano. And go ahead and give -8 with a diopter and a quarter of sill on that eye. Now, many of you are probably sitting there about ready to scream at me, but what about the image size? And I'm going to say, what about it? It's minified, okay? It's still a focused image. And the only way you're going to find out if vision has got a potential of improvement is to deal with that now. If vision does improve, then I would say go ahead and think later on about using anisoconic approaches, try to deal with the image size inequality. But for now, I would go ahead and I would just try to do that. Would I ever think of doing any kind of patching? The answer is probably no. I probably wouldn't. Why? Because there's no way that that right eye, unless it gets better pretty quickly, is going to provide any kind of a level of vision in a 5 or an 8-year-old kid that's going to be functional enough for this kid to be able to get around, to deal with school, to watch TV, to look at his phone, all the things that people do in life. So that's probably what I would do. I would follow the kid, and then I would make changes as we go along. All right, let's take some questions.
Okay, so we'll just wait for some answers or some comments by our attendees.
Actually, I should ask, is this working out like this with asking questions? Is this okay to people in the audience?
I think yes, it's quite working out, and we are getting tremendous replies as well.
Great.
We won't be able to answer all, but I think we'll try to take maximum, and the others we'll try to answer in some other way, I guess.
Yeah, just give me a couple of the juicy ones.
Yeah, yeah. Would you consider contact lens as an option because of the refractive errors being so different?
Yeah, great question. The answer is absolutely later, not now. So
Okay.
that would absolutely be a possibility later on. And it's, I think, probably the best approach because, you know, pair of spectacles with a -8 on one side and plano on the other is like going to tip the kid's head to one side. So, yeah, contact lens absolutely later on.
Okay, and somebody thinks that this 5-year-old kid has a good level of tolerance on the anisometropic prescription. So probably that's the reason we should go ahead.
I agree. I find that I'm surprised with kids how little problem anisoconia is in most cases. Adults, different story. Fortunately, I have almost no experience with adults. I'm happy about that. With kids, kids seem to adapt amazingly.
Okay. Okay, yeah, contact lenses, yeah. A few people are again saying contact lenses would be their choice, and absolutely later would be the choice, yeah. Okay, any other suggestions and comments? We are waiting for them. There was one particular question for the follow-up schedule for the last case, I think, and
Okay,
probably you would like to highlight that. In the meantime, we are waiting. So how
sure.
would you do a follow-up schedule to monitor the progress of the vision?
How would I monitor the vision in a child where I can't get reliable visual acuity measures?
Yeah, or once you prescribe, you want to see that prescription is helping out the patient. So how frequently you would do the follow-up visit? Is it monthly or you
How
would see them
frequently?
after 3 months?
So the first
Ah,
visit is 2 to 4 weeks, and then typically every 6 weeks after that, until I get a leveling off of visual acuity. And then at that point, I would start more active forms of treatment. I like to follow more often than less often, and I do that in part to maintain the management. I think obviously the management piece of it is incredibly important. And I think that if things are starting to go wrong, I want to find out about it sooner rather than later. If compliance in particular is becoming a problem, I want to find out about it and I want to try to figure out ways of dealing with improving compliance.
okay. And one more question related to the last case was any issue about the e-metropization process you would be considering for prescribing?
Yeah, I think that's a good thing to think about, but I would argue that if you've got that level of hyperopia along with amblyopia, even at the age of 3, I would say that emmetropization is already broken and is not going to be regained. In other words, if you've already had a significant problem like accommodative esotropia that has developed, emmetropization is in a sense now off the table. It's no longer something to think that much about, a little bit. So I guess the next part of that question is it likely or is it possible that the level of hyperopia may through natural history decrease over time? And the answer is, of course, yes, it might. And that's why you have to keep on top of these things. So things change and you have to change with them.
Okay. And coming back to the anisometropic case, there was one comment that they had a similar case recently, and they prescribed the full correction, but then they started on patching the good eye. So
Yeah,
for
I
two
think
hours a
patching,
day.
it's okay. There's nothing wrong with it. And I might very well begin patching at some point. Um, to me, it's less likely that amblyopia is an issue. It's more likely that it's just the optical blur and that the visual acuity is going to improve pretty quickly just by beginning to use the eye. Is that another way of saying there's maybe a somewhat different kind of amblyopia in unilateral high myopes? And the answer is maybe. Maybe it is a little bit different. Probably it is a little different. I don't think there's anything wrong with doing patching. I think it's fine. And I probably would give that a try myself at some point. So I think that's perfectly appropriate to consider that. And if you've had success with that approach in the past, then by all means, continue with that approach in other patients.
And the duration should be about 2 hours a day. I mean, is there any?
Sure. Yeah, I think something not too great and probably while the child is at home, not at school. So I have more of a control over the environment. You don't want to impose the patch on the child at school for social reasons unless you really think you need to do that. That's maybe another part of what TS studies have taught us. Minimizing the social adverse consequences is really important in maximizing compliance. So everything we can do to improve compliance is an absolutely critical element of the treatment process, maybe the most important of all.
Yeah. And how would you probably deal with kids who would refuse to wear the glasses because of the probable diplopia or anisocoria what they experience, if there is?
I just don't find that the anisocoria is an issue, and in my experience, diplopia really isn't. Suppression happens quickly in these kids. So I'll give a little bit of a maybe off-color answer to the question. I would probably use crazy glue to glue the glasses onto the kid, and probably tie the kid's hands behind his back to leave him there for at least a few weeks.
So whatever comes, maybe you want them on with glasses. There's no option for them to be off glasses if they come to you, I guess.
No, you know, if the kid is not going to tolerate glasses, is he going to tolerate a contact lens? Would that, the lack of tolerance of glasses, does that make that patient a better patient for contact lenses? I think you know what the answer is. The answer is no. If you have a compliant patient, that's a contact lens patient. If you have a non-compliant patient, that's the last person in the world you'd want to put a contact lens on and have any expectation of success. Non-compliance with glasses, in my view, equals non-compliance with a contact lens.
Okay. And let's say if this was a case of an axial myopia, would you go with a myopia control? And if yes, how often does it work for your experience?
Well, as I said, in my experience, only very, very rarely do you see a significant amount of progression of myopia in these individuals. What you do get, and I'm sure everybody on the call right now will acknowledge this, is when you do retinoscopy of this kid, you get a certain measure. But if you're off on that retinoscopy by a couple of degrees, you may very well hit an area of the back of the retina that is in a staphyloma, an outpouching, and you may find 5 diopters more myopia at that point. In other words, your ability to refract this kid is problematic and totally dependent upon fixation, because the location of where that retinoscopic reflex is reflecting off the retina is going to determine dramatically what the prescription is. And my experience is that my, let me call it, inaccuracy of my first prescription is almost invariably due to my inability of getting an optimal retinoscopy. I'm not getting the best reading I can. I just don't find these eyes progress very much. If they do, then of course, do what you have to do. Trying to deal with myopia progression in these individuals, our ability of, and I don't want to get too much into myopia progression. It's a whole different issue, and I'm not an expert on it. But we're not certain about all the ways of mitigating myopia progression at this point. We have a lot of tantalizing clues. We have a lot of suggestions. We have a lot of things we're doing in clinical practice, but in no way should anybody think that we've got the answer to this now. We do not. So if we don't have the answer to a 2 or 3 diopter myo progressing, do you think we have the answer to a 10 diopter myo progressing? The answer is no, we don't. We don't have a clue. So I just don't think we're in a position to really think about dealing with myopia progression. And how do you deal with it unilaterally anyhow? I don't know. Let me go on to the next case.
Yeah.
I'm not going to talk about simple myopia. Let's talk about bilateral high hyperopia. This is a situation that is often thought to be very uncommon. In my experience, this is not uncommon. I can't tell you how many hundreds, maybe thousands, of kids I've seen over the years that are like this. I'm going to modify this case just a little bit. I'll leave this on the screen, but let me tell you specifically about one kid that I took care of that is absolutely in my brain. I can't ever forget this kid. Mom brings a 3-year-old kid in to me for an examination. This is long ago. The mother was a pediatric nurse practitioner. She was a highly experienced pediatric nurse. She was responsible in her clinic for the vision screening program of all children in that clinic. She was somebody who knew a whole lot about vision and vision screening of young kids. She was really pretty expert. She was a smart lady. She brings the kid in, gives me the history. The history is as follows. The babysitter after school, 15-year-old babysitter, just a kid, kept telling this mom that your child has got a vision problem. The mother kept saying, the expert mother kept saying, My kid does not have a problem. I know about kids with vision problems. My kid does not have a problem. The babysitter just kept going at the mother for months and saying, your kid's got a problem, your kid's got a problem. So finally, the mother says, all right, I'll satisfy the 15-year-old babysitter. Let me bring the kid in for an exam. Brings the kid in for an exam. Initial visual acuity was 2200 in each eye. Okay, this kid's got a problem. But her ability to maneuver in the room, her ability to walk into the room and sit down and do some things visually was relatively normal. One of the tricks that I like to do, and you might find this amusing, that I like to do with a child that seems to have or is reported to have poor vision, but doesn't look like they do. I'm always thinking about that case of malingering that we all talk about, and probably some of you have seen. A kid who says, I can't see, I can't see. You do your exam and there's nothing wrong. So one of the things I like to do is pick up a ball, just a small ball, and throw it at the kid and see if the kid can see it and catch it. And of course, this kid could see and catch the ball no problem. So I'm thinking, all right, this kid is a young malingerer. Unusual at that age. You don't usually get that till adolescence, but okay. So I do my exam, and it turns out that my refraction dry is a +12 in each eye with a little bit of sill, +12. Big, huge pupils, undilated with any drops, but huge pupils. What's this kid have? Well, I look in the back of the eye with my ophthalmoscope and I dial in, and yeah, it's super high hyperopia, very small optic nerve head, very tightly congested vessels. This is a classic case of bilateral high hyperopia with badly decreased visual acuity. And we use the phrase, and this was brought up in the amblyopia talk the other day, isometropic amblyopia. This child has been living in a blurred world since birth. This child has never had a clear image on the retinas of either eye. So in a sense, this is not a typical form of refractive amblyopia. This is a very atypical form that in many ways has aspects that are more similar to deprivation amblyopia that one gets from congenital cataracts or complete ptosis. So this is a far more dramatic and severe form of amblyopia than typical refractive amblyopes. 2200 acuity. Now, one thing I want to reiterate is the pupil size. Now, if you have a patient with moderate to high hyperopia with large pupils when you're doing retinoscopy, what should that suggest to you? This child is undergoing absolutely no accommodative effort. The child with the +3 or +4, the first case I presented today with the accommodative esotropia, what did I see on initial examination on that child? I saw tiny pupils. Why did I see tiny pupils? I saw tiny pupils because that kid was accommodating to overcome the hyperopia. This kid, on the other hand, is accommodating zero, no accommodation. If I was to try doing accommodative testing in my normal manner of this child, I would find grossly deficient accommodation. That's a key element. When you're doing retinoscopy on a child dry, and for those who are unable to do wet retinoscopy, can't use drops, this is really important for you to hear. And you probably already know this. Doing that retinoscopy, you get the kid to look far away, the pupils open up, you know that kid is relaxing accommodation. When those pupils constrict, you know the kid is using accommodation, and therefore you're getting an anomalous retinoscopic prescription. You want to try to get that kid to look far away, relax accommodation, and then you'll get something closer to a cycloplegic refraction. If those pupils are small, you're getting almost the opposite of a cycloplegic refraction. So in this particular case of the isometropic amblyopia, huge pupils, really, really bad accommodative ability, super high refractive error, congested retina. Now think about, this is another interesting thing. You think about the number of photoreceptors in an average eye, whatever that number is, whatever tens of millions of photoreceptors exist in an average eye. If you have a really big super myopic eye, a -10, like in the last case, does that kid have more photoreceptors? Answer, no. What that kid has are photoreceptors that are literally stretched far apart. Maybe think about social isolation today. Think about this case here of the super high hyperope. Are there more photoreceptors? No. Same number, just packed more tightly together. Number of photoreceptors doesn't change from average. Highly myopic eyes, stretched far apart. One of the reasons why visual acuity can't reach a maximal level in these super high myopes is because they don't have the same pixel density that you would get on a great computer screen compared to a really bad computer screen, where the pixels are large and you can actually see them on the screen, compared to a super duper computer screen where you can't possibly see the pixels because they're so small. Same deal, but the opposite in this case of high hyperopia. Everything is congested. The retina looks congested. The vessels look congested. So acuity is bad. What do? What I do is I provide almost all, but not all, of a hyperopic correction. And I do that because, again, I want to focused image 360 both retinas simultaneously. So I give pretty much what I found. In the case of, say, +12, I would give maybe a +11. Why that much percentage am I giving? Because what I don't want to do is I don't want to initiate another set of problems from happening. If I cut the plus dramatically, I reduced it enough that that kid now might, under some circumstances, be able to exert accommodation to overcome the remaining amount of uncorrected hyperopia that's present. You might trigger an accommodative esotropia in that individual. I don't want to do that. I want a focused image, but I don't want to initiate another set of problems. Now, I'll give most of the correction, but not all of it. Why not all? Because I want now to begin a form of accommodative training. I want to initiate some necessity to accommodate. This kid is never accommodated. I want to start the process now of beginning some accommodation. This kid comes back 25 years from now, there will be dramatic deficits of accommodative ability still remaining. This kid will never develop normal accommodation, no matter what you do. It's like somebody having a dramatic physical handicap at birth. No matter how much therapy you provide, this kid is never going to be a long distance runner. Same situation here. So what do? Instead of 12, I'll give 11. I'll see the kid back in a couple of months. Visual acuity will probably begin improving slowly, but consistently. In this particular child, I got to follow this kid for about 25 years, literally. I followed this kid until she graduated medical school, believe it or not. What I saw is over time, she would pick up about 1 line of acuity every year or so. This was a slow rate of progression, but not atypical. When the amount of hyperopia is more similar to what's on the screen right now, you may pick up a line every 6 months or every year. You probably won't ever get to 2020. You'll probably get to 2030, something like that. There'll still be a deficit. It won't be perfect. So this situation, isometropic amblyopia caused by bilateral high hyperopia, almost always over 5 diopters need to be present. It is exacerbated by having high SIL in addition. That complicates it even further because then there is a meridional amblyopia component, potentially superimposed over this isometropic component. So, slow improvement, you need to do accommodative vision therapy over a period of time. There is no patching to be done. There are not a whole lot of binocular techniques that you might be able to utilize to speed up the process or improve things. But you might try that if you want. It would be, I think, not an unreasonable thing to do. But the accommodative business is important. And I would add that when this kid was old enough to need to have enhanced ability of reading, something like 4th or 5th grade, let's say, then you might need bifocals in order to enhance near visual acuity. I'll stop there and be happy to take some questions about this case.
Okay, just wait for some comments and questions, Prof. And okay, would you possibly do any alternate occlusions in this case?
No, absolutely not. Occlusion is not necessary. There's nothing to be gained by occluding. There is no deficit related one eye to the other. So doing any kind of patching, even alternate patching, is not going to give you anything in addition. I should add that there are a couple of the ATS studies that specifically looked at this situation, and they pretty much follow what I described in terms of treatment, best treatment. So there's now an evidence basis for approaching it in this manner.
Okay. Okay, we are just waiting for some answers or comments to come. I think people are still typing it out. So.
Okay.
Okay. Would you consider IOL implant to emetropize? Is that a good option?
No, that would be a bad option. Putting an IOL in a healthy eye simply does not only not make sense, it would also be contraindicated because doing a surgical procedure inside the eye always has significant risk of complications. The complications could be retina, but in this case, where you have a small eyeball, and I should say one additional thing, I did some studies, other people have done some studies looking at why these are small eyeballs. What's small about these eyeballs? Well, long ago, I did a study looking at ultrasound measurements of kids with bilateral segment of the cornea, hyperopia, and we found that the answer to the normal in configuration. Cornea may be steep, but otherwise the distances between the structures are normal. However, the distance between the back of the crystalline lens and the sclera is massively reduced in size by as many as 4, 5, 6 millimeters, even more than that. So you have a posterior pole that is small. But because the tissue is congested in the small eyeball, your risk of glaucoma, of causing some form of glaucoma, whether open angle closure, or closed angle rather, closed angle, or whether some kind of drainage mechanism glaucoma is exacerbated in these individuals. So there is a significant additional risk of glaucoma at some point in life in individuals with high hyperopia. And I think you're all familiar with that. With moderate hyperopia, the issue of angle closure, particularly in Asian populations, is really very widely understood. So it's related to this. You don't want to go in, you don't want to do anything inside the eyeball unless you need to.
Okay. And when would you start considering accommodative vision therapy for this case, if you were to?
As soon as is reasonable. Again, my point about undercorrecting a little bit is maybe a first stage of accommodative stimulation. I'm trying to get literally the individual to begin using accommodation. I would say that it totally depends upon the age, the ability of the child, the family, all of that. But I think initiating accommodative vision therapy as early as possible absolutely makes sense, and use all the tools you have available.
Okay. And if, let's say, the child would have an alternate ISO deviation, would the
They don't.
prescription?
They simply do not. These
They do
eyes,
not.
actually, this is an interesting phenomena. So that question, I guess, is implying that there is a tendency because of a hyperopia to have an ESO situation, whether esophoria or esotropia. Here's the surprising thing. These individuals always have exophoria, always exophoria. Every single individual I've seen has an exophoria. Why? No accommodative status. They're all exophores. Esotropia is non-existent.
Okay. Okay. And is it probably due to the intraocular muscle paralysis?
No, I don't think it has anything to do with that. I think it's just lack of use. It's disuse. There's never been a stimulus to accommodate. Therefore, the response is equally lacking. I think it's as simple as that, just disuse. Never used from the beginning. It's not even disuse. Disuse implies you used it and then you stop using it. In this case, you never used it. There was no reason to affect accommodation because the optical blur was so overwhelming that there was no stimulus to accommodate based upon a need for clarifying vision.
Mhm. And probably there is no motor response of accommodative convergence, so that's why there's an exophoria, as you mentioned.
Correct. So the whole
Yeah.
relationship between accommodation and convergence is abnormal in totality. So
Okay.
convergence is also lacking. And I guess, you could think about training convergence later on, but it's really accommodative convergence that you would be thinking about training, not convergence in isolation.
Okay. Okay. Yeah. Yeah. I think. Okay. There's one question which says that if the same case was about 4 months old, if the kid was about 4 months old, uh, would
Good
you normally
question.
see? Yeah.
First of all, you could ask the question, why would you actually see this child at 4 months of age? What would bring this child in? What would anybody notice about this child? Poor visual response. As I said before, what is surprising is the visual responses seem to be fairly normal, more so than you would imagine for that level of visual acuity that you can measure at 3 or 4 years of age. So you don't usually see dramatic impairment of visual function. It's a nice way of saying without a dramatic impairment of visual function, it's not all that likely that you're going to initiate a referral to come in for a visit because the parent's not going to notice anything wrong. Pediatrician's not going to notice anything.
Okay.
Would I do anything different? I might. I mean, I probably would not at 4 months of age do anything. I would absolutely watch this kid because what you hope for, what you pray for, is that emmetropization is going to happen, even though it's not likely with that high a level. But it could happen, and you don't want to mess with it. So I would watch really closely, and if I saw over a period of months nothing good happening, then I may very well provide strong hyperopic refractive correction, even in an infant.
Mhm. And I don't know whether it's a comment or a question. Mobile phone using is the major defect for this power. What's your take on that?
I'm sorry, say that again?
Mobile phone or electronic gadgets use is the major defect for this power, is it?
Is the
What's your
major
take?
defect for this power? You mean the major deficit in function is looking at a mobile
Yeah.
phone?
Yeah.
Yeah, I mean, I guess nowadays that's kind of the provocative test, isn't it? So if a kid is not able to use a mobile phone, we now think of that as a developmental defect, don't we?
Yeah.
Not true when I was born. Um, I guess that would be a way of identifying a kid at a young age. On the other hand, maybe they would still just keep poking around and just touching things, and it wouldn't look all that abnormal. I don't know. I don't know the answer to that. It's kind of an interesting thought, though.
Okay. And one question on retinoscopy, as you mentioned about retinoscopy being the most important tool. So what size of pupil do you consider it as a normal pupil size when you're doing retinoscopy in kids?
Well, kids have big pupils, don't they, under normal
Yes.
circumstances? So anything that's not big, to me, is abnormal. I see a small pupil in a child, immediately I am assuming I'm going to find significant degrees of hyperopia. For me, that's absolute. I mean, I teach that to my students. Small pupil equals trouble. Kids do not have small pupils. Now, babies do. So infants have small pupils, but by 3 years of age, pupils are not small anymore. So you're doing retinoscopy on a kid with a small pupil, they are a hyperope. What do I do to try to relax that and get a better estimation? I will put high plus lenses in front of both eyes. I will hold +4s, +6s in front of both eyes, and then begin my retinoscopy and keep pushing more plus until I find neutrality in those individuals. And I'll see it by the pupil getting larger as the accommodation is being relaxed. And I'll be able to push more plus that way. That's how I do my retinoscopy.
Any particular pupil size you look for, or is there any normal pupil size you want that pupil size and you consider that to be a good pupil size?
It's relative. And of course, you know, depending on where a kid is looking, if they look closer at that instant, pupil gets smaller. So, I mean, I expect to see fluctuation in pupil size, but I do my measurement. I call my measurement when the pupil is at its largest. So if I am doing retinoscopy and I don't see a big pupil, I will push plus in front of both eyes simultaneously. In other words, I'll fog until I get that. Now, if I still can't get a pupil that gets larger, then of course I'm going to put drops in every kid's eye anyhow. But if I still see small pupils when I'm trying to do my retinoscopy dry, then I know what I'm going to find wet. I know I'm going to find a ton of hyperopia. I always use my dry and my wet measurements together to determine what I'm going to prescribe or what I think the problem is. I don't do one without the other because I know, as I said before, I'm going to miss some kids with high hyperopia who either I'm not catching the pupil size properly or I'm missing something else. I know the fault is mine, it's not the kid, that I'm missing it. And I know that on a certain percentage, at least 10% of the time, that's going to happen. That's why I do dry and wet, and I use the measurements I obtain under both conditions. If I see a big difference between dry and wet, I know that that kid is accommodating a whole lot dry. If I don't see any difference, I didn't mention that in this case in front of us here, the high hyperope, I put drops in. I'm actually not going to find anything different at all than what I found dry. Effectively, my dry retinoscopy is the same as my wet retinoscopy because there's no accommodation.
Okay, and when you say large pupil, how large do you consider to be large?
You guys want to? You want a number? I don't know. I don't know what the number is. Big, moderate size to big. How big is that? I don't know. It's relative. I don't think any of us, as we're doing it, comes up with a number in your head. At least I never do. I mean, if I wanted a number, then I measure it. But I measure with a ruler. I can't estimate.
Okay. Yeah, I think these are the comments and questions for this particular case as of now, Prof. Yeah.
Okay, I'll go on to the next one then.
Okay, yeah.
All right, high astigmatism. Similar history. Kid failed division screening. Nobody knew the kid had a problem. Now, in the United States, in particular, we have certain ethnic groups that have vastly more astigmatism than other ethnic groups. So within the United States, in particular, Native American tribes, Indian tribes, some, not all, have huge amounts of astigmatism. One of my colleagues has spent a lifetime working with one particular tribe in Arizona, the Apache tribe, that has an average of 5 to 6 diopters of astigmatism. That's the average in that Indian tribe. There are other Indian tribes that really have none. We have large numbers of people who have immigrated from Latin America, particularly Central America in the United States. And in Boston, we have a lot of people from Central America. And I've actually spent a lot of time in Central America doing research, looking at some of these issues of astigmatism there. I've gone into some communities in Central America, some very isolated Indian communities, Mayan Indian communities, that also have an average of 5 and 6 and 7 diopters of astigmatism. In Boston, very typically, Central American kids have astigmatism just like what you're seeing on the screen. Lots of it at all different axes, including oblique. So this is, for me, a common problem to see. These kids have difficulty in school, for sure. Their ability to read letters is really pretty difficult. So if you think about the functional effect of oblique astigmatism to this degree, you would recognize that a letter like a V, the letter V, that has arms that are sort of at an angle, a 45-degree angle, is going to be either in focus or completely out of focus. If you think about astigmatism with a rule, against a rule, axis 90, axis 180, you think about a letter T. Either this arm is in focus, the horizontal arm, or the vertical arm, but the whole letter at one instant is not in focus. So instead of a child seeing a letter T, they might think it's a letter I or a hyphen. It can be incredibly difficult for these kids to be able to learn the letters because they simply don't see the whole letter at the same time. So this can be a really serious functional problem. And I think, as we all appreciate, the kind of amblyopia that you get is a meridional amblyopia. It is an amblyopia where the axis that is in focus is clear. The axis that is most out of focus is completely blurred. And with 5 diopters of astigmatism, it is really, really blurred and may be virtually invisible. So their ability to read a letter chart is compromised. But you might get certain hints about even the axis of astigmatism by the letters that they see or don't see. Now, obviously, if you do your refraction with a clock chart or anything similar to that, you'll also very, very easily see that. But if you think about how you might, with the greatest degree of accuracy, actually be able to measure visual acuity in an individual with dramatic meridional amblyopia, there is one technique that comes to mind that you may or may not be familiar with. I don't know if people know about the teller acuity cards or the preferential looking test that is used in mostly laboratory and a little bit of clinical settings to measure visual acuity of infants. Series of black and white stripes, horizontal or vertical, you can orient them in different ways. If you were to orient those stripes at the same axis as whatever the astigmatism may be, and then you measure it 90 degrees away, then you might get dramatic differences in visual acuity in the 2 orientations of the teller acuity cards. In a clinical setting, how important is it to know that? The answer is not really. You know that meridional amblyopia is going to have the effects upon letter visibility. And you know that what your goal is to try to improve on it like you do with any other form of amblyopia. So this child comes in, failed the vision screening, visual acuity is very inconsistent, and that's probably one of the most dramatic clinical findings when you're doing visual acuity testing, is you see how inconsistent the visual acuity findings are depending upon that orientation of the letters. The binocular status is probably poor in general. Depending upon the test used, it might be better or worse, but bottom line is visual function is poor in general. These kids are really compromised visually. So what do? Well, as we talked about quite a bit, what I would do would be to provide the full astigmatic correction. In this case, I would probably cut the plus, maybe quarter, half diopter, something like that. It doesn't really matter. I would give the full sill. I would give the exact axis, and I would put it on the kid. And some of you are thinking, if I go ahead and put on 5 diopters of sill on an individual, 2 seconds after I put it on, the kid is going to be throwing up. Now, that may be true with adults. They may get totally nauseous and disoriented and dizzy and fall down and all of that stuff. But I have to be honest with you, I just have not seen that response, for the most part, very dramatically in kids, particularly the younger kids. I really don't get that response much at all. You may get a little bit of it, and if you do, what I simply tell the parent to do is put the glasses on first thing tomorrow morning. Make sure they stay on. Don't let the kid take them off. In other words, don't give the kid the glasses, send them off to school. Keep the kid home that day, do it on a weekend, and make sure the kid has got the glasses on, and within a day or two, they will adapt to this quite dramatically, actually, in my experience. Now, I don't know if that matches your experience or your expectations, and I'm pretty certain that it doesn't match your experience with older individuals, maybe older kids, certainly adults, and absolutely with elderly people for the first prescription. But again, my experience with kids, it's like that. So what do I expect to find over time? Well, improvements in visual acuity, slow and steady, somewhat better, I think, than in the isometropic, somewhat faster, but not real fast in general. And often it doesn't get to fully corrected, even over a long period of time. If it is bilateral, as it is in this case, then it does get better. It doesn't usually get to perfect, but it can get quite a bit better. Now, what if this was unilateral? What if the right eye was as you see it and the left eye was plano? Well, then you got a problem, because not only do you have the spherical component being anisometropic, but the astigmatic component is, and you're more likely to get some of that sort of spatial disruption, spatial discomfort in those individuals. And I acknowledge that. I still would not modify my prescription. I would keep it with full correction. Again, focused image 360. Typically, vision gets better over time. It's fairly slow, slower than it would be if it was primarily hyperopic in component, but it typically does get better. And when it flattens out, then you start adding the other components of treatment. So I'll stop there and I'll happily take some questions again.
Okay, Prof. We have a couple of questions already. Is there a possibility that the axis might change significantly while doing the near task and leading to discomfort for this particular prescription?
So that's a great question. And we know that accommodation can actually throw a little bit of change of SIL into the equation. And I guess the short answer is, yeah, it probably can happen to some degree. Do I know how much? I do not. Is there an average? I do not know that. Does it happen with all individuals or only a small number? I don't know that. But what I do find is that it is, in general, from a clinical perspective, not as great a problem as the concept might indicate it could be. I would guess that probably in some individuals, it's more of a clinical issue than others. And if that's so, then I would really work hard on trying to understand. Obviously, it creates difficulty because doing a refraction like that on an individual with amblyopia, especially, is really impossible, because the ability of discriminating small changes in visual acuity by doing small manipulations of Jackson cross cylinder, for example, borders on impossible. I guess you might position yourself in a certain way and do a form of near-retinoscopy in that way. I haven't done that myself, but I appreciate the question. I think that there is probably clinically something to it, but I don't have a good answer to it. It hasn't really been something that I've thought much about. In retrospect, maybe I probably should think a little bit more about it. So that's a good question, but I don't have a good answer.
Okay, and how about the near vision in terms of these prescriptions on the first visit? What do you expect the near visual acuity to be?
Typically not much different. You know, in amblyopia treatment, we haven't put that much of an emphasis on near visual acuity. We probably should pay more attention to it, and in my research study, we are paying more attention to it as we're going through the next phase. I think it's certainly worth, evaluating near visual acuity in all cases. When I talk about acuity, generally I'm referring to distance acuity, but I think near acuity is equally as important, and one may argue in kids where their primary occupation is education, it's probably even more important. So I think it's certainly a valid question, and I think a valid argument that we ought to pay a lot of attention to near visual acuity. And if you had to choose to maximize one or the other, which would you do? Well, I think realistically, probably you'd put more emphasis on near visual acuity. So, great question.
Yeah. And just to add on the previous question, like there was one patient the person had where the axis was different for the distance as well as for the near. So I think the person went ahead promoting two different pairs of glasses, one for the distance viewing and one for the near viewing, because of the change in the axis.
I think it could make sense, but from a practical perspective, I'm going to guess that at the end of that first day, only one pair of glasses is going to make it home from school. The other one, I think, is not. I would worry about that. I would worry about how the system is going to break down. I don't know how you would get the kid to be consistent to change glasses depending on task and to hold on to both pair for a 12-hour period of time. You have a way of doing that, and let me know. I'd like to know. So I think it's theoretically it's reasonable. Practically, I just don't know.
And would you prefer RGP lenses for this particular case?
No, because what do you get with RGP lenses? You're going to get rotation anyhow. I think the precision of correcting visual acuity with RGP lenses, even the world's greatest bitoric lens, is unstable compared to a pair of glasses sitting on a nose. So if you're particularly worried about the vision, then RGP lenses, I think, are not the way to go. I mean, later on, for high school, for social issues and things like that, absolutely. But for dealing at a young age, I would not go that way.
Okay. Somebody comments that there are some ophthalmic lenses available that provide real-time compensation on the ocular rotation during near tasks. So probably they might help for these particular patients.
I'm not familiar with that. If there are, then I think that could be useful. I just kind of worry a little bit about how you would measure the refraction accurately at near. I don't know how you would do that, particularly if visual acuity is compromised at all. Visual acuity is excellent, then you have a better chance of being able to measure it accurately.
Okay. And this kind of astigmatism, probably, is it corneal in nature?
Good question. It can be. It usually is, but it isn't always. I mean, you can have somewhat tilted crystalline lenses. That could do it, which of course then makes you start thinking about stuff like Marfan syndrome or homocystinuria, some of the other disease entities, syndrome entities. Primarily, it's corneal, and in our Native American and Hispanic populations in the U.S., when we've really looked at it closely, invariably it's corneal in nature.
Okay. And is there any particular community or ethnicity where it will be more of a corneal astigmatism, according to your experience?
Well, I'll just comment on this. In the fall, before coronavirus hit, I was in Mongolia, actually, for a period of time doing some work there with children. And to my surprise, we found a ton of astigmatism in some of the Mongolian populations, particularly the more tribal people. So I think that there are populations all over the world, would be my guess, that have high degrees of astigmatism. And it may be in minority populations in various countries. It may not be in the dominant population groups. But I think that there are subpopulations, probably pretty much everywhere, that will have high degrees of astigmatism. I think I've seen some of that in Vietnam also, among some of the minority populations have had higher levels of astigmatism than the more dominant populations. So I don't know if that answers that question, but I think that this issue of high astigmatism is really everywhere, at least in selected populations.
Okay. Okay. I think let's take one last question, Prof. Do patients get meridional suppression in these particular cases?
I'm sorry, can you say that again?
Do patients get meridional suppression?
Meridional suppression? Huh. Guess I haven't thought about that. I don't know. I don't know the answer to that. It's an interesting question. Don't know.
Okay. Yeah, I think those are the questions. I think we have covered most of them here. That's fine. Okay, thank you very much, Prof. I think we had a very wonderful learning session and understanding on the prescribing trends, of course, based on situations and your perspective and your theories and your inputs on prescription. So thank you very much, Prof. I think we'll see if we can do another session where we can go towards some more complicated cases and understand your inputs on that. Okay.
I appreciate everybody's attention and hope this is of some value to all of you in your day-to-day practices. These are all patients that you see. They're all coming into your offices, and I think it's useful for you to get some additional perspectives on evidence-based approaches to managing these patients. So again, thank you for your attention, and sleep well.
Thank you, Prof. Have a good day ahead. And special mention to the Optometry Vietnam team. I think they also shared our screen, and I think a lot of people in Vietnam also had a chance to listen to you and get your experience and listen to your talk. So thank you very much to the Optometry Vietnam team as well. Okay. So yeah, I'll just share my screen and just let them know for the session what we have tomorrow, Prof. So tomorrow we have a session which is on ocular prosthesis. Okay, so let me just get my picture. Yeah, so we have Dr. Kuldeep Raizada, and he's an ocularist, an optometrist, and a leading ocularist, I would say, in India. He has a vast experience in prosthesis. So he is going to talk to us about the clinical guidance for examining patients who require prosthetic eyes. So please tune in tomorrow. The timings are 6 p.m. in the evening India time and 8:30 p.m. Malaysia time. I hope to see all of you tomorrow, and good night and stay safe, stay home. See you all again. Bye.